Hello guys, hope you're all okay. You're enjoying your life. You're also enjoying watching my videos and everything would be alright on your part. Today I'm going to discuss about the ovarian neoplasm. This is the series of my previous lecture, previous videos. In the last videos, I have discussed about certain ovarian abnormalities. So I'm gonna just repeat just to give you an idea what this video would be all about. You know that ovarian neoplasm categorized into four. The one is epithelial tumors, the another is germ cell tumor, the third is sex stromal card tumor, and the fourth one is a metastatic tumor. So these four are the main categories. The first category was epithelial tumor. So epithelial stromal tumor has been discussed in previous lecture. If you want to look, you just get back to my video and you will get all the information related to that, because that epithelial tumors were very common and it includes 7 to 80% of ovarian neoplasm, and majority of them are happens to be cancerous. Today my topic of discussion is the second category, that is called as germ cell tumor. So germ cell tumor is divided into three. So in germ cell tumors you will come across with cystic teratoma or maybe Germinoma, and the third is Yolk sac tumor. So these three tumors are called as germ cell tumor. So today my topic of discussion would be germ cell tumor, and I'm gonna cover this germ cell tumor in this video. What is germ cell tumor? A germ cell tumor account 15 to 25% of the ovarian neoplasms, and majority of them would be malignant. So first of all is the cystic teratoma. Cystic teratoma is very common germ cell tumor, and especially this you will see in young ladies, young girls, and young women. So this is a malignancy, and when there is a cystic teratoma, in other words, cystic teratoma is also called as dermoid tumor. We usually know this tumor is well known with the name of dermoid tumor. So dermoid tumor is very common, and whenever you come across dermoid tumor in ladies in her 50s or 60s, always consider there would be malignancy, because there is a malignant potential in dermoid tumor as well. Dermoid tumor derivatives are ectoderms, endoderms, and mesoderms, and it contains some dermoid plugs, which appears as a tooth or hair or fat. So there are multiple presentations of dermoid cyst, multiple appearance on the ultrasound and CT scan. So you will see a lot of information on this video if you just stuck to this video and keep watching, because dermoid cyst is very common, and it appears a very large mass, solid mass having dermite plug within it. It appears hypoequic, it appears with a reticular lining, it appears as a mural cystic lesion with a mural nodule, it appears highly bright echogenic, sometimes it appears as a fat fluid level. So multiple varieties are there. So if you keep watching this video, you will be able to get information about the cystic teratoma. So this I'm going to explain how cystic teratoma will look on the ultrasound imaging, how it will appear on the CT scan. So let's start watching these images for the cystic teratoma. Cystic teratomas are composed of well differentiated derivatives of the three germ layers. These are ectoderms, mesoderms, and endoderms. Because endoderms elements generally predominate, that's why cystic teratomas are virtually always benign. Sonographically, cystic teratomas have a variable appearances ranging from completely anechoic to completely hyperechoic. These includes predominantly cystic mass with a highly echogenic mural nodules, the dermoid plug. So you may come across with the dermoid plug, that is the tip of the iceberg sign. It's also called as tip of the iceberg sign. Then in some of the cases you may be able to appreciate dermoid mesh. It has its own particular radiological appearances. Very rarely you may be able to see mobile spherules, and fat fluid level is the commonest sign. So let's start watching these images and to appreciate all these features to confirm the dermoid, or in other words cystic teratoma. This is transvaginal scan, and on this transvaginal scan you can appreciate right ovary, Right ovarian parenchyma is clearly visible. There are multiple cysts. These are called as follicle, mature follicle, you can appreciate. But the one important feature, this is echogenic nodule. Within this ovary, you can appreciate well defined reflective echogenic lesion. You may call it as a nodule, you may call it small mass, you may call it as a lesion, whatever you prefer. You can apply all these terms on that, but this is a specific form, specific characteristic feature of cystic teratoma. This is also called as dermoid. Normally we call it as a dermoid. So this dermoid is within the ovary is clearly visible. This you can appreciate on the transvaginal scan. Transabdominal scan will not help you in this regard, because this echogenicity, this lesion echogenicity will be quite confusing with the bowel content. So there will be reflective echoes from the bowel as well, so you won't be able to appreciate that. Only the transvaginal scan will help you to identify the ovary, and within the ovary this dermoid can be seen. So this is an example of dermoid lesion, and dermoid may appear in this fashion, and it may appear within the ovarian parenchyma. This is transabdominal scan, and on this transabdominal scan, the pelvic area, the U is indicating uterus, and this is the right adnexal region. In the right adnexal region, indicating by white arrow, you can appreciate a well defined, highly reflective, highly attenuating mass lesion. Only the surface part of the mass is visible, because of the fact that all this area having increased echogenicity, and because of this increased echogenicity, lower part is obscured. So only tip of iceberg, this sign is called as tip of iceberg, this is visible, and this is the sign of dermoid cyst. So dermoid can be seen in this fashion, and this can be easily picked. Quite commonly you can appreciate dermoid in this form, and this will show tip of iceberg. While you are scanning the patient on the abdominal, from the abdominal area, you make sure and confirm that you are not confusing with the bowel loops, because bowel loops will give rise the same appearances. The only distinguishing point would be you go and you just palpate the area with the hands and find is there any mass palpable or not. If there is mass palpable, put the probe on and find. If still you can appreciate this tip of iceberg sign, so it is confirmed that this is dermoid lesion. This is a transvaginal scan, and on this transvaginal scan you can appreciate that a highly reflective large echogenic mass. Actually this is within the ovary, and ovarian parenchyma has been replaced by this mass. This is dermoid cyst, this is cystic teratoma, and quite common appearance. This appearance, clinicians knows all these appearances because this is a quite common. But if in case there is bowel contents and intraluminal fecal contents are there, so it will give rise to the same appearance. It's quite difficult on the transabdominal scan. For that reason you need to have the transvaginal scan. On the transvaginal scan it would be easy for you to confirm. If clinician is expert and if he has seen all these type of dermoid lesions and cystic teratomas in his clinical practice, so he may be able to pick that on ultrasound, abdominal ultrasound. But in unexpert clinician, this would be quite difficult. So it is better that to go for the transvaginal scan. Transabdominal give you a clue. If you find that there is something wrong, and on the palpation you still may feel that there is some tumor lesion, go for the transvaginal scan. On the transvaginal scan you will be able to pick this type of appearance. This is a particular radiological appearance which is called as characteristic echogenic lesion. It is entirely echogenic. It has obscured the entire ovarian parenchyma. This is within the ovary, and this is another feature and appearance of the dermoid lesion. Look at this transvaginal image, and on this transvaginal image you can appreciate two particular radiological pattern which are identical for the dermoid lesion. So the first one is called as hair fluid level. So these, which is indicated by the long arrow, this is hair fluid level. This particular it will called as a reticular pattern. So you can appreciate reticular pattern. On the right side you can see anechoic fluid, and on the left side you can appreciate this reticular pattern. So this is called as hair fluid level. So this is the one thing within this lesion. This is a cystic lesion and this is cystic teratoma. This is the one radiological finding. You can appreciate this is hair fluid level. The another finding pointed by the another curved arrow, this is called as fat containing dermoid plug. This has actually high contents of fats. Because of high contents of fat, this becomes highly reflective. So this plug you can also appreciate. This is called as fat containing dermoid plug. So this is another feature. So within this cystic lesion you can appreciate two particular radiological pattern. The one is hair fluid level, which is on the right side. On the left side you can appreciate there is a fat containing dermoid plug, which is a characteristic of dermoid lesion. So I'm sure you will not miss that if you come across with this type of a lesion having both reticular pattern and dermoid plug. Sometime this is likely that only you may see only one appearance. Maybe reticular pattern would be visible, or maybe you may be able to see only dermoid plug there. Whatever the case, this is dermoid appearance. Another radiological pattern is called as fat fluid pattern. This is transvaginal scan, and on this transvaginal scan you can appreciate a well defined boundary in between the fat contents and the fluid, which is indicating by the white arrow. This is called as fat fluid level. Fat is always deposited downwards, so this is a dependent part. In the dependent part, because of the consistency of the fat, it gravitate towards the base. So that's why the basal layer or the dependent area is highly ecogenic. So this ecogenic area is fat. So, and after that there is a fluid level. So this forms a particular pattern, fat fluid level. So fat fluid level is another common appearance of the dermoid, and majority of the case can be seen with the with this radiological pattern. So dermoid cyst or dermoid lesion may appear in this way. So this is called as fat fluid level, and fat will be in the dependent area. In some of the cases, sometime you will see some of the ecogenic patterns which appear as a supernatant, but in this case this is deposited downward and this forming fat fluid level, and this is dermoid lesion. Another characteristic radiological pattern for the dermoid cyst or cystic teratoma, on this slide you can appreciate this is transvaginal scan, and on this transvaginal scan you will appreciate three important features. The one is there is homogeneous echoes within the lesion. So this is the one pattern. The second thing, indicating by the white arrow, these are calcifications. So multiple tiny calcifications can also be seen in there. You can call it calcific foci, and beside that there is a cystic area. So cystic areas, homogeneous ecogenic pattern with calcific foci. This is another pattern of the dermoid lesion or cystic teratoma. So cystic teratoma may appear in this fashion. So you have to give a concentration on sometime while focusing only on calcification or focusing only on the cystic area, because these are quite easy to pick on the ultrasound imaging. You forget the surrounding part, which while this cyst is actually as a whole containing these three features, and you have to measure as a whole, that this would be exact measurement of the dermoid. So this is dermoid lesion, and it will appear radiologically in this pattern. This is another characteristic radiological pattern which you can appreciate in the dermoid lesion or in cystic teratoma. This is transvaginal scan, and on this transvaginal scan a well-defined complex cystic lesion can be seen. Now if you want to write these patterns, so how you will write that? So you have to take the measurement of this cystic lesion and then mention that there is fine reticular pattern which is called as dermoid mesh, and beside this there is also a highly echogenic reflective lesion casting aquastic shadowing, which is called as dermoid plug. So in this cystic lesion there are two patterns. The one is dermoid mesh and the another is dermoid plug. Dermoid plug is formed by highly echogenic contents due to the fat. So this is fat components. So because of the fat, this is highly reflective. So this is a dermoid lesion, and dermoid lesion showing two radiological pattern. The one is dermoid mesh, appears as a small tiny reflective echoes, which is representing as a reticular pattern. So reticular pattern would be considered as a dermoid mesh, and beside this there is a dermoid plug, which is in the dependent area. Because of the highly fat content, it becomes echogenic and this forms a dermoid plug. So these two patterns can also be seen in the dermoid or cystic teratoma. So as I mentioned that cystic teratoma has variety of appearances, you should have to have a look for all these identifications and appearances, not to forget that this is an important lesion. Although it's benign, but still it needs attention because of its management. This is another transvaginal scan, and on this transvaginal scan a complex cystic lesion can be seen. If you're not focused, so you might miss that because it looks very weird pattern, and this is also called as dermoid mesh. Within this dermoid mesh, the one thing you can appreciate is highly reflective lines are visible. So these tiny interrupted lines are called as dermoid mesh. So this dermoid mesh having small tiny dots and echogenic lines. This is the one finding, and the second is you can also appreciate small tiny or larger dots as well. So these are dots and tiny lines forming an dermoid mesh. These all characteristics are floating within the liver, within the cystic lesion. So this is a dermoid mesh. So it may appear in this way, but if in case you are not focusing, so it looks like this is all the shadowing from the intestinal contents. This may represent as contents within the bowel loop, fecal contents in the bowel loop. So it's a quite confusing pattern. But if you are focused and beside your ultrasonic imaging, you are asking the relevant questions, and beside this you are also palpating the area. After palpation, if you come across and you noted that there is some mass, solid mass, and on the basis of your this examination, you correlate with your ultrasound finding, you will ultimately reach to the diagnosis that this is dermoid cyst. This is very unusual pattern. This is actually transabdominal scan, and on this transabdominal scan you can appreciate multiple mobile spherical echogenic structure floating in the large cystic pelvic mass. This was a large cystic mass which was seen on the transabdominal scan in the pelvic region, and within the pelvic region you can appreciate that these all round spherical echogenic lesions are floating within the cystic lesion. This is another characteristic of dermoid. Although this is not very common, but still it can be seen, and a dermoid lesion, cystic teratoma, may appear in that fashion. So this was all about these all slides were particularly showing characteristics of cystic teratoma, and you may come across with these type of radiological appearances. So if you have seen all that, so this would be in the back of your mind, and while you are scanning, if you come across such lesion, it will come into your conscious, and you will realize that this feature and these characteristical features I have seen somewhere. So you will eventually reach to the conclusion that this is dermoid lesion. But in these all form, these are all different from one another, and it needs attention. Sometimes some of the lesions you may be able to pick on the transabdominal scan, while some of the lesions may need transvaginal. So therefore correlate your transabdominal finding with transvaginal finding, and beside this, if patients say that she feels some mass within the pelvic region, go for that and palpate the area and on the exact position perpendicular to that lesion, go and put your probe on, so you will definitely see something wrong, and that would be your conclusion, and that would be your real diagnosis. Dysgerminoma is another malignant, highly malignant germ cell tumor, and it arises from primitive germ cell, undifferentiated germ cell. This usually seen in younger ladies less than 30 years of age. This germinoma is morphologically similar to male testicular seminoma. This is highly radiosensitive, and you can find 5-year survival rate between 70 to 90%. So, for the ultrasonic imagings are concerned, it happens to be a solid mass, predominantly ecogenic. But beside this, you may be able to see cystic degenerative changes and necrotic in it. So, how it will appear on the ultrasound imaging and how it will appear on the CT scan, because the CT, MRI, and the ultrasound is the modality to pick the germinomas. So, germinoma is again the germ cell tumor. As I explained, the germ cell tumor is divided into three: the cystic teratoma, and the germinoma, and the Yolk sac tumor. So this is the germinoma. So germinoma is highly malignant, and how it will appear on the ultrasound imaging, let's start watching these images, and you will be able to pick the germinoma. Dysgerminoma is a malignant tumor of the ovaries, and it's quite identical to the male testicular seminoma. Sonographically, they are solid masses, and predominantly ecogenic foci can be also be seen, or predominantly ecogenic appearance can also be seen, but they may contain small anechoic area caused by hemorrhage. As far as this scan is concerned, this is transabdominal scan, and on this transabdominal scan you can appreciate a well-defined, predominantly hypoechoic lesion. Although margins are regular, margins are normal, within the lumen you cannot really pick the necrotic areas or cystic degenerative changes, or there is no calcification within that. It is adjacent to the uterus, so this appearances are quite confusing. Straight away the first conclusion would be a pedunculated fibroid, because it's more look like a fibroid, but actually this is not the fibroid. It has nothing to do with the uterus. This is in the adnexal area. In the right adnexal area, this large, predominantly hypoechoic mass is dysgerminoma. Although in this case you cannot appreciate internal necrosis or internal cystic degenerative changes, which are the common characteristic features of dysgerminoma. Dysgerminoma is always malignant. This is another presentation of dysgerminoma. Dysgerminoma is a malignant tumor, and this transvaginal scan shows large, solid ovarian mass with thin linear hyperechoic areas. Here in this image you can appreciate thin linear echogenic areas within the lumen, within the parenchyma of this solid mass. This is ovarian mass. Although you cannot appreciate the necrotic areas or cystic degenerative area, this is predominantly solid lesion, and in the appearance, so far the appearance is concerned, it is called as a heterogeneous lesion. So this heterogeneity is because of this echogenic lines. So this echogenic lines gives rise to a heterogeneous pattern. This is germinoma, and this germinoma can also present in this fashion as well. So this is highly malignant tumor, and as I mentioned, this is identical to the male testicular seminoma. Both are malignant tumors, both have a large malignant potential, and this is germ cell tumor. So germ cell tumors comprises of cystic teratoma, dysgerminoma, and Yolk cell tumor. So this is dysgerminoma appearance on the ultrasound. This is a transabdominal scan, and this transabdominal scan shows large but bilateral ovaries. Here, both on the right and the left side, bilateral ovarian masses with increased vascularity is seen. In the right side tumor, you can appreciate the vascularity clearly, which extend over the uterus. Just adjacent there is a uterus, and it's overlapping over the uterus as well. Note that enlarged left ovary due to tumors. So left-sided tumor is also left-sided ovary is also enlarged. So here you have to pay attention to visual to see and to pick the point for the dysgerminoma. Whenever you do transabdominal scan, you will come across this type of a feature, and this would be quite confusing with the fibroid, because fibroid also appears in this way. Whenever there is confusion, go and to look for the landmark of the uterus. If the uterus is visible and it is on the it's separate from this lesion, then go for the ovaries, look for the ovaries, search for the ovaries. If ovaries are there, and you can pick something within the ovary, so this would be definitely ovarian lesion. In this image, downward, uterus is lying below that lesion, so it means uterus is safe. It could not be confused with the fibroid. The second thing is vascularity. This is a highly vascular lesion because of its blood supply, because of its malignant potential. So this is the example of dysgerminoma. Yolk sac tumor. Yolk sac tumor is another rapidly growing malignant tumor of the ovaries, comes after germinoma. So this germinoma is the first and the second most malignant tumor. Very rapidly growing tumor is Yolk sac tumor. It is usually seen in ladies with under 20 years of age, which is a common indicator. So if there is a ovarian tumor and the female age is less than 20 years of age and there is increased serum alpha protein level, so you may suspect Yolk sac tumor. As far as sonographic features of Yolk sac tumor is concerned, it is similar to this germinoma, but so far the age differences are concerned. If it is less than 20 years of age, so you may suspect Yolk sac tumor. So let's talk and let's discuss about all that. But as I mentioned, so far the radiological features are concerned, Yolk sac tumors is similarly to dysgerminoma. So whenever there is dysgerminoma, there is likely possibility that this may be Yolk sac tumor. You have to look for the age, and after that, if there is a problem, you may put that into your differential. Yes, guys, this was all about the germ cell tumor. And as I told you that this was the series of my previous video in which I have discussed about the epithelial tumors. If you want to go through the epithelial tumor, just get back to and watch my other video, because epithelial tumors are very common and it accounts 70 to 90% of the ovarian neoplasm. As far as germ cell tumors are concerned, these accounts 15 to 20% of all ovarian neoplasm, and germ cell tumor comprises of cystic, teratoma, dysgerminoma, and Yolk sac tumor. So these three tumor has already been discussed, and I'm sure you may be able to get all these informations from this video and would be able to retain and produce at times when it needed. So for this information is concerned, it's not quite difficult, but the one thing is very important. Keep in mind that cystic teratoma is quite common, 95% it's benign, but still there is potential of malignancy. So whenever you come across with all these features, uh, just confirm that this is cystic teratoma. One another point, sometime if this cystic teratoma appears as an echogenic, it may mimic as a bowel loop. In that case, you straight away go to palpate the abdomen, and if you did find there is a tumor, so then you can confirm that this is not the bowel loop and this is not the content within the bowel loop. This shadow is because of the cystic teratoma or dermoid cyst. So make sure that your diagnoses are confirmed. If you have any queries and if you have any doubt, just get back to me and I will get back to you with my reply. Keep watching my videos and keep giving me your feedback. If any other queries you have in your mind, just drop me a message. With some other new video, we'll see each other. Till then, take great care of yourself. Bye bye.